All right, so we're recording now, just so you guys know.
Well, I appreciate that Asheville sort of retains some heat at nighttime because New Mexico does not.
Yeah.
Which is not what I was expecting. And then somebody told me, they were like, well, it's a desert. Like there's nothing to retain the heat.
Right.
So we do have like all 4 seasons. It just only happens like between the hours of like 10 at night and 6 in the morning.
Right.
Cool. I'll give it about 1 more minute, then I'll, as folks are simmering in, I'll go ahead and do the announcements in about.
All right, I'm going to drop off the radar here.
All right, I'm gonna go ahead and get started with the opening announcements. Greetings, everyone. Thank you for tuning into today's Law and Mental Health webinar. My name is Anthony, and I work for the University of New Mexico's Department for Community Behavioral Health. Before we get started, I have some quick announcements regarding the CE evaluation link. So if you have any questions, please submit them in the Q&A box throughout the presentation. To receive a certificate for the eval link, you must attend the full hour presentation. About 5 minutes before the end of the presentation, I'll put the eval link in the chat. Once you complete the eval, you'll receive your certificate digitally. It's your responsibility for saving a copy of the certificate. Please save the document to your desktop or screenshot the certificate if you're using a smartphone or a device. If you're joining by phone and don't have access to the chat, please shoot us an email and we'll get you what you need. All right, and I think that is it. We're letting more folks join in. Julie, I'll go ahead and hand the floor over to you.
Thanks, Anthony. Welcome everyone to the University of New Mexico Law and Mental Health Didactic Series. This series is hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences and the New Mexico Behavioral Health Services Division. We're so glad to have you all here to join us today. My name is Julie Brovko. I'm an assistant clinical professor in the Department of Psychiatry and Behavioral Sciences. So first, I want to announce that we are accepting applications for our forensic postdoctoral fellowship. We have 2 spots available for the 2021-2022 year. Our brochure is ready to go, so email me if you'd like a copy. Next, I want to remind you to join us next week. At that time, we are so excited to announce that we have Elizabeth Loftus and Jeff Youngren, who will be presenting Truth and Falsehoods in Memory. So make sure you jump on to that. For questions that you might have today, we're going to be holding them until the end of the talk. Please ask them anytime you feel comfortable, but just note we won't get to them until the end. And finally, for those of you who are on a tight schedule but still need your CEUs, I will let you know when the hour has passed. We'll likely be staying on longer to address questions, but to qualify for those CEUs, you only need to stay for the hour. So now it's time for what we're all here for. I'd like to introduce to you our speaker for today, Dr. Shawn Acheson. Dr. Acheson earned his doctorate in clinical psychology from Southern Illinois University in 1997. He completed specialized training in clinical neuropsychology during internship and his postdoctoral fellowship in the Department of Psychiatry and Behavioral Sciences at Duke University Medical Center. He has spent most of his career teaching and conducting clinical and preclinical research on TBI and the neurodevelopmental effects of alcohol and marijuana. In 2011, he joined the Duke Center for Psychiatry and Law and served as the lead psychologist from 2015 to 2017. He also served as a staff neuropsychologist in the compensation and pension and neuropsychology clinics at the Durham VA Medical Center from 2016 to 2017. And in 2017, he returned to private practice in lovely Asheville, North Carolina, where he provides clinical and forensic neuropsychology services in clinical, criminal, and administrative courts. Dr. Acheson, on behalf of the University of New Mexico, the Department of Psychiatry and Behavioral Sciences, and New Mexico's Behavioral Health Services Division, I'd like to welcome you and thank you so much for presenting today. We're so grateful for your time and expertise, and I'm now going to turn it over to you.
Thank you, Julia, and thank you to Jeff and everybody else at the University of New Mexico. As I said to them earlier, I discovered these back in March or April, and I've hardly missed a single one since. These have been great, and I hope mine will rise to the same level as so many of the others that I've been able to participate in. So thank you again. So what I'm going to talk about today is mental health in the age of COVID and the forensic implications of COVID. I did a similar talk back in June for the Western North Carolina Psychological Association when I talked a little bit about COVID and the brain and how the virus and the corresponding disease process itself affects brain function and cognitive function. And so this is kind of an update and an extension of that specifically for forensic purposes. So let's move on. It's my brief bio, my disclosure. I have no financial interest in the topic of this presentation. The views expressed in this are mine and not those of the University of New Mexico. So there's really sort of three primary learning objectives for today. And we will take these one at a time. There's been an immense discussion about SARS-CoV-2 and the pandemic and the corresponding quarantines and how those have shaped what we do. The move as psychologists, the move to virtual evaluations or video conference-based evaluations, what can and can't be done in a virtual environment, the modifications that we have to employ to routine face-to-face evaluations to improve safety for ourselves and those that we evaluate. And these issues have all very significantly affected the practice of forensic psychology, especially in light of the difficulties to access in jails, prisons, and state hospitals. There seems to have been far less discussion, however, on how the pandemic will shape the questions we're asked to answer. The ailments, complaints, concerns that clients or examinees bring to our office are also going to be affected by COVID, both directly and indirectly. The purpose of this talk is to raise some awareness of the potential impact of COVID and the corresponding pandemic on who we see and what questions we answer. In addition to the how we practice. If there's time at the end, we can talk about some of those practice modifications, but that's not really the overarching goal of this talk. There've been plenty of other talks, including some here on this in this platform, this University of New Mexico platform. But there are several ways to think about and talk about the mental health effects of SARS-CoV-2 and COVID and the pandemic. And particularly the public health response more generally. There are those who suffer the effects of the virus and the disease directly, and then there are those that experience it vicariously. So in terms of the first objective, we're going to summarize the cognitive and mental health effects in COVID patients. There are real and substantial adverse effects of the SARS-CoV-2 virus. I'll talk briefly about the virus and the disease, or how the disease affects our physiology, and then I'll talk about the effects on our cognition and mental health. With regard to the second objective, there are the psychological effects of proximity, the impact we experience vicariously. When we discuss the vicarious impact of SARS and the COVID disease state, our thoughts often go to those who are closest to it, the frontline workers, people like direct care medical staff, public safety, police officers, firefighters, and EMS, the jail and prison staff, although obvious to us as forensic mental health specialists, I think the public is less aware of the physical and mental health ramifications for those kinds of folks. There are transit workers, there are the grocery store workers. All we need to do is think about all of those businesses that were considered essential businesses that remained open during the initial lockdowns. I don't want to suggest that these frontline workers are all alike in terms of vicarious exposure. They're certainly not. Rather, I think it's important to understand that being on the front line really exists along a continuum. And at some level, we're all on the front line. We are all at risk for exposure and infection and bad outcomes. I also want to draw our attention to the idea that the experience of frontline workers goes well beyond what we typically think of in terms of vicarious exposure. The notion of vicarious trauma and secondary traumatic stress has been around for decades and it's gained ever greater traction. But generally speaking, these concepts refer to the exposure to the traumas of others, listening to, understanding, helping clients deal with their traumas. It's been written about in various professional domains, mental health providers in the context of PTSD treatment and evaluation of sexual abuse, to name a few. Support staff in refugee camps are known to experience vicarious trauma. Social workers investigating various forms of abuse. Forensic mental health providers. Gianni Pirelli has a paper this year in 2020 on various trauma and burnout in forensic mental health providers. It's a great paper. But SARS and COVID really is in many ways different. It is certainly true that the frontline workers, this is not simply exposure to the death, disease, and the traumatic experiences of others. It's really more than vicarious. They are genuinely at risk. Their lives themselves are literally at risk. These doctors and nurses and others are exposed to the agent that is killing the people they are seeing die. So it goes, I just want to emphasize that it really, in many circumstances, it goes beyond vicarious to more firsthand, potentially firsthand trauma. Let's see. And then the third objective, we'll discuss some of the issues of relevance to our forensic practices. There's not an immense to talk about there, but we'll get to that later on. Really, the goal is to raise awareness of what COVID is doing and SARS-CoV-2 is doing and how that is relevant to the kinds of things we will see in our practice. Although we probably haven't seen much of it yet, there's a lot coming, at least I think. So before we get to those objectives, I want to talk a little bit about some background. I want to set the stage. I think it's important to help sort of define the problem. And there's a lot of talking around SARS and SARS-CoV-2 and COVID and what the differences are. SARS-CoV-2 is the causative viral agent of the disease state known as COVID-19. SARS stands for severe acute respiratory syndrome. CoV-2 is the coronavirus, and it's the second such coronavirus to cause SARS, the severe acute respiratory syndrome. It's recognized as a genetic variant of the original SARS coronavirus that had an outbreak in 2003. It's the second such SARS outbreak, and so it's SARS-CoV-2. It is one in a family of coronaviridae viruses, not all of which cause SARS. This coronavirus family of viruses is actually a very broad family of viruses. They're so named coronaviruses because of the crown-like appearance caused by the spike proteins that you can see around the body of the virus itself. This is just a photomicrograph from an electron microscope that shows sort of the overall structure of the virus itself. It's not a bacterium, doesn't respond to antibiotics. The coronavirus, as I said, are very common. They are essentially what constitute the common cold. They are rarely dangerous. They are more rarely fatal. They tend to affect the nose, the sinuses, and upper throat. Most, as I said, constitute the common cold. However, SARS-CoV-2 is radically different. It is more potent a killer and has more morbidity associated with it than the prior SARS outbreak. COVID-19, on the other hand, is the disease state caused by SARS-CoV-2. It was first identified in 2019, hence the name COVID-19. It is not, as some talking heads suggest, the 19th version of COVID. It is the 2019 novel coronavirus. Often people ask, why the different names? Why are we confusing SARS-CoV-2 and COVID? And it's important because one is the viral agent, one is the causative agent, and one is the disease state. It's much like the distinction between HIV and AIDS. HIV is the human immunodeficiency virus, and AIDS is the corresponding syndrome, acquired immune deficiency syndrome. A couple of other important notes about SARS-CoV-2. It's not simply like other coronaviruses. It is a novel coronavirus, one our species has never before encountered, and one for which there is no innate or established immunity at the current time, or at least at the time that it crossed from other species to humans. It's a zoonotic virus, meaning it was transmitted from other species to humans. Though the development and severity of COVID varies across the population, and in some it may be more severe, it's not a product of some having established immunity to it, at least not yet anyway. And that's an important distinction that I think we should all keep in mind and should help drive social distancing and support for quarantines and lockdowns. People that have not yet been exposed to it simply don't have an immunity to it. There is an immunity that appears to develop after exposure, but that immunity may or may not be permanent. We don't know at this time. There's also evidence that SARS-CoV-2 is mutating at a rate that may make permanent immunity maybe unrealistic. So we're just not sure yet. There's just, we've only been at this for a little over a year, right at a year. So there's just so much that remains unknown. The good news, as of the end of last week and this week, there appears to be really promising results from Moderna and Pfizer on vaccine trials. But there's unfortunately little in the way of a clear plan for distribution and to whom that virus will be distributed first. So the Pfizer vaccine has to be kept stored at -90 degrees Celsius. And the Moderna vaccine has to be stored at, I think it's 4 degrees Celsius. These are very cold temperatures. Most doctors' offices and pharmacists are going to struggle to keep it that cold to keep the vaccine from going bad. So there's a lot of infrastructure that has to be brought to bear to adequately distribute this vaccine in a meaningful and effective way. It's not clear who's going to get it first. Certainly those on the front lines, those at greatest risk, but those have not been defined yet, as far as I can tell. Certainly medical staff first-line medical staff are likely to be amongst those who get the earliest doses. Elderly and immunocompromised are likely to be high on the list. Police, EMS, firefighters, maybe jail and prison staff. And it's not clear where mental health is going to fall into all of this. Mental health has been typically classified as an essential business in this pandemic. I like to think psychologists and other mental health providers will be high on that list. We just don't know yet. So stay tuned on that. Well, time is flying. Okay, so let me skip over some of that. All right, so where are we now? let me go back to something. Sorry, a little thrown off by the time. That some people are relatively unaffected by SARS-CoV-2 or develop only a mild form of COVID-2 shouldn't reduce our attention to the dangers. For some people, many in certain demographic and medical communities, there is no question that the SARS-CoV-2 virus is an absolute monster. At present, it's very difficult to determine for whom it will lead to nothing versus those for whom it is an absolute killer. Viral load is almost certainly an issue. That is how much of the virus you're actually exposed to. But again, that is still not well understood. It's also important to remember that any one of us can be a vector. Any of us can shed virus before we realize we're sick, regardless of how sick we get. Screening for symptoms is not a guarantee that one is virus-free or not shedding the virus. Another coronavirus that's often discussed is something called MERS. It's the Middle Eastern Respiratory Syndrome. It's also a coronavirus. We'll talk a little bit about the case fatality rate with SARS. The MERS had a 34% case fatality rate. So 34% of those who were exposed were known to die. So fortunately, we're not talking about a MERS kind of pandemic here. So the question now is, where are we now? So as of yesterday, according to data, national data, we're at 238, just over 238,000 deaths. We're at just over 11 million confirmed cases, all within the US. That's a current case fatality rate of 2.2%. That's down, fortunately, from what is a high of about 5.6% in and around the beginning of June. Some of that decline in case fatality is probably due to three different factors. We have increased and improved surveillance, so now we're able to identify milder, non-fatal forms, which increase the case count relative to deaths and which lowers the overall case fatality rate. There is improved management of the most acute illness, the most acute and severe illness. Not that there is a known treatment, but doctors in ICUs and in emergency departments are just better able to manage the symptomology. There's lower demand on resources. Cases are somewhat more distributed now than they were previously in April and May. So we were getting a lot of fatality just from overrun ICUs and emergency departments. The cases seem to be a little bit more spread out across the country at the moment, or at least had been until very recently. And so more resources were able to be brought to bear on the cases that were there. It's probably not unreasonable to expect that case fatality rate to tick back up a little bit in the coming weeks as demand for limited resources increases, though hopefully it won't climb back up to the nearly 6% it was in June. While the media tends to portray ICU bed availability as determinative of the level of crisis, the greater issue really is the availability of staff and equipment. There are roughly 107,000 ICU beds nationwide across all categories. So that includes med-surg, cardiac, neonatal and pediatric care, burn units, and other miscellaneous ICU beds. As we see here, there's currently only 14,000 people in ICU. There's 73,000 currently hospitalized due to COVID, but only a little over 14,000 in ICU. So we have plenty of ICU beds theoretically. The question is really, do we have enough critical care staff to monitor all of those beds simultaneously? And that remains to be seen. The great majority of those 107,000 ICU beds are centralized in tertiary care facilities in metropolitan areas, which means limited access to rural communities, which seem particularly hard hit at present. The Dakotas, in particular in the Rio Grande Valley in Texas, seem to be real, and areas of Wisconsin seem to be really hard hit. And so the cases, again, are on the rise. So the deaths are up 6.7% over the last 7 days, up. Total number of cases is up 11% over the last 7 days. Mechanisms of action. So when we're talking about the cognitive and mental health effects, they're gonna arise from COVID via one of these 4 mechanisms. Typically, there is direct viral infiltration of the brain. There are effects on the CNS directly and indirectly through the periphery from these cytokine and inflammatory agents. Sometimes you'll hear them referred to as cytokine or inflammatory storms. Those happen both peripherally or systemically in the body, and they also happen within the central nervous system. And both the systemic and the central inflammatory crises can affect neurological and cognitive function. There's a lot of hypoxia and respiratory distress and related multi-organ dysfunction that arises. This is typically associated with an acute respiratory distress syndrome. And aside from COVID, acute respiratory distress syndrome does have its own cadre of cognitive and mental health effects. And then there's the psychological and behavioral mechanisms, the trauma, the fear, the anxiety, the social isolation. All of that occurs in both patients directly and non-patients vicariously. So let's talk, this is sort of the beginning of objective 1. So I want to summarize here the cognitive and sort of neurological impacts of COVID. Some of what we know of COVID's impact on cognitive function is actually attributable to what we know about the related pathologies. So other SARS and coronavirus outbreaks helps to inform us of what we're likely to see. We're still deep in the throes of this. It's going to get much worse, unfortunately, before it gets permanently better. So some of what I'm going to talk about is based on what we know about the MERS and the original SARS outbreak. Some of these secondary medical crises that arise, mechanical ventilation, multi-system organ failure, these can be their own contributor to cognitive and neuropsychiatric consequences. So it's not necessarily COVID specific, but it's the result of these medical crises that are secondary to COVID. So a recent study out of New York, this is a paper by Frontera et al. This year. They included a study of 4,491 patients, all hospitalized with COVID, and 13.5% of those developed some new onset neurological disorder within 2 days of the original COVID symptom onset. So 6.8% were identified with encephalopathy, which again is not unique to COVID, but happens very often in these ICU kinds of situations. 1.6% were reported to have seizures, 1.9% were reported to have stroke, and 1.4% were reported to have hypoxic or ischemic injury to the brain. Those at highest risk were for these neurological outcomes were older, white, hypertensive, diabetic, intubated, and individuals with organ failure. Controlling for those variables, those risk variables, those patients with new onset neurological risk of death and had lower likelihoods of being discharged home. So these do not portend well when you have the encephalopathy, seizures, stroke, and hypoxic or ischemic damage. It does not predict good outcomes. These incidences seem low, 6.8%, 1.6%, 1.9%, 1.4% all seem low. But remember, there's 11 million cases in this country. There's 73,000 patients in the hospital. Multiply those percentages times those numbers, and we're still talking about the potential for hundreds of thousands of these events. And in many cases, these things are not mutually exclusive. The encephalopathy, the seizure, the stroke, the hypoxic and ischemic injury, these are not entirely separable events, but some folks have more than one of them. These, as I said, these neurological disorders carry their own risk for cognitive, behavioral, and mental health consequences, and really increase the likelihood of permanent or long-term consequences. Let's talk a little bit about the delirium and then the encephalopathy. As I said, this is a common occurrence in ICUs, independent of COVID. So this really comes as no surprise, but is sort of standard in severe ICU kinds of conditions. Both are associated with greater COVID morbidity and mortality. Some of the data indicate that this underlying pathology is a better predictor of long-term outcome than viral load itself. That is the amount of virus someone has in their body. And so this makes for a challenging situation in understanding who is really at greatest risk for the worst outcomes or the longest term outcomes. The role or impact of SARS-CoV-2 in the brain remains a little bit unclear. It's clear that SARS-CoV-2 does invade the brain, it does get into the brain, but it's not clear how much of the long-term consequences are actually the result of invasion in the brain. Recent postmortem studies appear to suggest that severity of COVID neuropathology was unrelated to viral load. And so time will simply have to tell about that. Specific cognitive outcomes have been difficult to identify. As I said, we're still deep in the throes of this pandemic. And this, in many ways, is a much more serious pandemic than either the original SARS or the MERS outbreak, based simply on numbers. Who wants to do a neuropsych eval on a COVID patient right now? There's not a lot of people signing up to do that study right now. So again, we will know more as time proceeds. There is a nice recent meta-analysis by Rogers, and he included in that meta-analysis studies from both the SARS-1, the MERS outbreak, and a few studies from the current SARS-CoV-2 pandemic. The resulting collective sample size was a little over 3,500 virus-positive patients, and the following prevalence rates were identified. In terms of acute impairments, we see a 38.2% prevalence of attention and concentration problems, a 34% prevalence of memory problems, 27, almost 28% prevalence of confusion in the acute phase of the illness. In terms of post-illness prevalence, and this is tricky because each of these papers defined that post-illness period in various ways, but beyond the acute hospitalization or acute ICU phase, we know that 20% of folks were still experiencing attention and concentration problems, 19% were experiencing memory problems, but less than 1% were still experiencing confusion. Moving on to the sort of basic mental health outcomes of COVID positive patients. In that acute phase, again, this is still the part of the Rogers meta-analysis, anxiety, depression were about a third of people in the acute phase of COVID were experiencing anxiety and depression. In terms of post-illness, those numbers dropped to 12 and 10%. Euphoria was less common, both in the acute and the post-acute phase. Aggression was not unheard of in the acute phase. Very low prevalence rates in the post-acute phase. Irritability, emotional lability are certainly prevalent enough that we would want to pay attention to them or be aware of them in our own dealings with patients. Auditory and visual hallucinations were present, not particularly prevalent in the acute phase, certainly less so or non-existent in the post-illness phase. More psychiatric or psychotic symptoms, persecutory ideas, 4% in the acute phase, 2% in the post-acute phase, and unspecified sort of psychotic symptoms were at roughly 4% in that post-illness phase. Again, this is a very complex disorder, and this is a very complex and disturbing virus, and we simply don't understand all of the mechanisms. And to preview some of sort of the relevance for our forensic practice, if we are seeing someone in a criminal setting or even in a civil setting who suddenly has sudden onset late life psychosis kinds of symptoms and are COVID positive, we shouldn't automatically suspect that this is malingering or made up symptoms. This can happen with COVID. And so it just helps to, I think, demonstrate some of the things we need to pay attention to in our own practices as we deal with people who have had COVID. Suicidality and self-harm. Though these numbers are low, we'll talk about this a little bit more with the vicarious exposure. I think the concern about suicidality and self-harm should actually might be much greater than what these numbers suggest. In terms of frequency of recall for traumatic memories and fatigue, both of those are readily prevalent in that post-illness phase. So in terms of risk factors, again, this is all derived from that Rogers meta-analysis. Females are at higher risk for PTSD. Among COVID positive patients, females are at higher risk, almost 4 times greater risk for developing PTSD, a little over twice as likely to develop chronic illness, almost 2 times greater chance of developing moderate or severe anxiety or depression. Healthcare workers who tested positive are 3 times more likely to develop PTSD, almost 4 times moderate to severe, developing moderate or severe anxiety or depression. Those COVID patients that have a history of chronic physical illness are almost 4.5 times more likely to develop PTSD, but not as likely to develop moderate or severe anxiety or depression. Those who experience a lot of SARS-related worry prior to their diagnosis are more likely to develop chronic illness. Those who identified a chance locus of control were significantly more likely to develop PTSD. Those COVID positive patients with a SARS family death, that is someone in their family who had already died of SARS, were 3 times as likely to develop anxiety or depression. Those who experienced frequent recall of SARS-related memories or nightmares were 13 times more likely to develop any current psychiatric disorder. And then, not surprisingly, those involved in some kind of medical legal circumstance were at almost 8 times greater chance of being diagnosed with any current psychiatric disorder. I want to talk a little bit about this notion of long haulers. There's been just an enormous amount of talk about long haulers and long-term consequences of COVID. There are these enormous social media groups on Facebook and others that have literally tens of thousands of members. There's been a lot of discussion in the popular press, on NPR, the New York Times, about these long haulers. And I'm going to be doing a separate continuing education in February on this long haul phenomenon. The problem is we just don't know. This is a novel, highly complex coronavirus that has profound effects on numerous organ systems. There remains a great deal we don't know about the pathophysiology of COVID and SARS-CoV-2. We don't know what the normal recovery curve looks like, so it's hard to refer to someone as a long hauler until we really know what a normal hauler looks like. This is a list of some of the symptoms that people are reporting. Symptoms vary from person to person. There is no universally accepted symptom profile. There's no clear pathophysiological model to explain symptom persistence, though there are some models emerging, but they remain very speculative and there's no real data yet. Many of the symptoms are these classic non-specific symptoms reported in other psychopathologies such as depression and anxiety and PTSD, as well as other medically complicated disorders such as mild TBI and concussion, Lyme's disease, and conversion disorder. I wouldn't argue that all of this is conversion disorder or psychosomatic for everyone, but it's clear that these issues need to be carefully considered. We can't fix, we can't make accurate diagnoses if we're not aware of what we're not aware of. So I think everything needs to be kept on the table at this point. What complicates all of this is that many folks are reporting these long haul symptoms in the absence of any significant acute illness. Many of the folks that are reporting long haul symptoms were never hospitalized. Many of them never even received a positive PCR or antibody test for the virus itself. Now, some of this legitimately is because of our very, very poor handling of the testing process early on. Many people who were symptomatic, but mildly symptomatic, were simply told, go home and stay home until you can't breathe and then you can come back. And so couldn't get a test. And when things got really bad and they came back, that secondary illness had kicked in and taken over, but there wasn't sufficient virus left in their system to test positive. So that some of these long haulers tested negative or didn't have a positive test at all is not entirely unreasonable, but certainly makes it very complicated to know and understand what this long haul phenomenon really is. I think as I said, I think we need to keep an open mind with regard to the extent to which some of these symptoms, rather than being the long-term consequences of COVID or SARS-CoV-2, could be symptoms associated with the corresponding psychopathologies, the depression, the anxiety, the PTSD that comes about secondary to the rest of the disease process. I'll draw your attention quickly, because we're rapidly running out of time, to two quick articles that I think are really great articles. There's an article by Hunningsbaum and Krishnan in the Lancet from last month called Taking Pandemic Sequelae Seriously, from the Russian Influenza to COVID-19 Long Haulers. It's a nice overview, sort of a historical perspective of long-term consequences. And then there's another sort of news drop in JAMA last month by Rubin. And the name of that article, and all of these will be in the reference list at the end when we send this out. That article is called "As Their Numbers Grow, COVID-19 Long Haulers Stump Medical Experts." And so both of those, I think, paint a picture and provide some insight into the nature of this long haul phenomenon that we need to be attentive to. Because I think these long haulers are likely to be, for those who do a lot of civil evaluations, personal injury, psychological injury kinds of evaluations, I think, or disability evaluations, I think these long haulers are gonna occupy a lot of our time and resources. All right, moving on to the second learning objective, identifying vicarious mental health effects of COVID among the public and those on the pandemic front line. Excuse me. So the original plan for this talk was to focus on the vicarious trauma primarily among frontline workers and primarily among healthcare workers. And while we don't want to dismiss or diminish their experiences and the importance of the work that they do, I think focusing solely on that group really misses an enormous segment of the population. The literature on COVID and mental health writ large is actually enormous. And as a proxy for a very broad overview of all mental health outcomes, I really want to focus on sort of these four issues, primarily the first three: suicide, substance use, and PTSD. With regard to suicide, as I said, it's a bit too early to tell. There are, however, factors in the US that certainly increase risk along with the obvious effects of COVID. There's a recent paper by Rieger, Stanley, and Joyner in 2020 that note that the US is at the highest age-adjusted suicide rate since 1941. Economic stressors, social isolation, appearance of barriers to mental health care, physical illness and medical problems, particularly in the elderly, anxiety provoked by national news coverage, surges in gun sales, all portend elevated risk, if not a frank rise in numbers. At Duke alone, there were 3 student suicides between mid-March and early May. It's not clear whether those were necessarily or specifically related to COVID and the SARS-CoV-2 crisis. But having been at Duke for 13 years, I don't ever remember a situation in which we had 3 student suicides in 6 weeks. So it's a very, very real thing. The CDC's morbidity and mortality weekly report for June 24th through 30th of this year asked those respondents, those 5,470 respondents, whether or not they had seriously considered suicide in the previous 30 days. Data from that MMWR report suggests almost 11% of those respondents had seriously considered suicide in the previous 30 days. Those at greatest risk for suicidal ideation were males. 13%, almost 13% of males reported suicidal ideation, serious suicidal ideation. 25, almost 26% of those between the ages of 18 and 24 reported suicidal ideation. African Americans and Hispanics, 15 and almost 19% prevalence amongst those two groups. Those with educations lower than high school reported a 30% prevalence of serious suicidal ideation. There are others. In terms of risk factors from that MMWR report, those with previously diagnosed anxiety reported a 24% prevalence of suicidal ideation in that prior 30 days. Those with prior diagnoses of depression, 22% prevalence of suicidal ideation. And amongst those who had a history of PTSD, almost 45% of those individuals reported serious suicidal, considered suicide in the previous 30 days. All right. So as a general marker of psychological distress, I think that suicide data suggests significant distress among the public. Remember, these are non-COVID patients. This is the public writ large that we're talking about. In terms of substance abuse and alcohol abuse, alcohol, let's be clear, alcohol is not a medicinal remedy or prophylactic for SARS-CoV-2 or COVID. You can't protect yourself by drinking more. As much as we might want that to be the case, it is not. Once again, it's early. We don't have a lot of hard data on SARS-CoV-2. But we do know from the original SARS outbreak in 2003, there was increased alcohol dependency and abuse as part of the aftermath of that event. And it was particularly true amongst hospital employees. We also know from that time frame that mandatory quarantines for various causes was also associated with rising abuse and dependence. There's a study published recently by Pollard that looked at alcohol sales. While that is not specific to abuse or dependence, it certainly sort of indicates a pattern of potential misuse. So for the week ending March 21st, 2020, so early in this pandemic, compared to the same week of 2019, in-store alcohol sales were up 54% relative to the same time the previous year. Online alcohol sales were up 262%. And it got worse. For the week ending April 25th, compared to the same week in 2019, in-store sales were up only 26%, down from the 54% the month earlier, but only because people continue to discover online sales. So online sales in that last week of April relative to the year before was up 477% relative to the prior year. So clearly there is a steep rise in alcohol consumption during this pandemic, which again suggests considerable concern with regard to abuse and dependence. That CDC morbidity and mortality report that we talked about before also talked about the prevalence of individuals starting or increasing substance use to cope with pandemic-related stress or emotions. And there are some disturbing numbers in all of that. I'll just name a few of them. For those aged 18 to 24, 25% reported that they had started or increased substance use to cope. 20% of those aged 25 to 44 reported that they started or increased substance use. For those with previously diagnosed anxiety, 26% reported that they had just started or increased substance use to cope with the stress. 25% of those with a prior diagnosis of depression. 44% of those with a prior diagnosis of PTSD. Moving on to trauma and PTSD. Evidence from the SARS and MERS outbreaks clearly point to increased risk of PTSD and post-traumatic stress in healthcare workers. There's a nice overview and meta-analysis by Carmassi this year. This is just a review paper. It's not actually a meta-analysis, but I think it really helps to identify some very important risk and resilience factors in frontline healthcare workers. Level of exposure in terms of risk factors, level of exposure was significant, at least in terms of perceived threat of exposure. Those in high-risk positions demonstrated higher rates of PTSD and post-traumatic stress than those in low exposure or lower risk roles. Interestingly, this is not universal. In a separate study by Lee published this year, frontline nurses reported lower traumatization scores than either non-frontline nurses or the general public, suggesting that some of those frontline nurses were probably better prepared to cope with these stressors than non-frontline nurses who were called in to this pandemic as sort of backup and support staff. Occupational role is clearly a risk factor. Nurses were at much higher risk than physicians, and this appears largely due to exposure time. Nurses have much more face-to-face time with sick patients than doctors do. I don't think anybody's suggesting that nurses are somehow more vulnerable than doctors are. I think probably quite the opposite. Age and sex are to some extent important risk factors. The younger healthcare workers appear to be at greater risk, probably due to fewer years of experience. The findings regarding sex, males versus females, is really quite mixed. Some studies report males at higher risk. Some studies report women at higher risk. So I'm not sure there's a clear answer on that one. Marital status is an interesting finding. Again, that's mixed. There's some indication that those that are married with families are actually at greater risk. Some studies show them to be at lower risk. And it's not clear why that is. I suspect it has to do with fears associated with in bringing something home and infecting the rest of the family, or isolation from those family members when they have to self-quarantine because of their job. Previous psych history is also a significant risk factor amongst these healthcare workers. Resilience factors, again, the flip side, family and social support, in some studies shows some resilience. Supervisor and colleague support is a resilience factor. Training is a resilience factor. The more people are prepared to deal with this kind of work, the better they are able to avoid the negative mental health consequences. And coping strategies, positive coping strategies, humor, planning, altruistic acceptance of the occupational risk, that is knowing what you are in for when you sign up to be an ICU physician or nurse, seems to play an important role in protecting people against the negative outcomes. Given the time constraints, there's another issue that I'm not going to spend really any time. I just want to mention, and that's this notion of moral injury that I think is just in its early stages. People who end up healthcare workers who end up having to make critical decisions about rationing or triage, I think are at greater risk for for moral struggles about having to make those kinds of life and death decisions that are just not typical of healthcare workers' experience. And there'll be some references in the reference list on that I think are worth reading. PTSD in the context of a raging infectious pandemic is certainly not limited to healthcare workers or even frontline or essential workers. We've already seen what has occurred with regard to potential increases in suicidality, alcohol, and substance use. It's not a stretch that exposure to the pandemic and the isolation and all of these other matters can also lead to PTSD. There's a paper by Thanos Karatsias and colleagues that make a very compelling case for why the COVID-19 pandemic constitutes a valid criterion A for the DSM-5 PTSD diagnostic criteria. There's two papers. There's an initial paper in June and a reply in October in the Journal of Traumatic Stress that I think really lays out a nice argument for why we should anticipate a significant number of people reporting, of the general population reporting PTSD. want to go back to that CDC MMWR report from June 24th to 30th again. Again, 26% of those responding to that survey reported new onset either trauma or stress-related disorder. 46% of those aged 18 to 24 reported new trauma or stress-related disorder. Of those previously diagnosed with anxiety, 52% reported new onset COVID-related trauma or stress-related disorder. Among those previously diagnosed with depression, 45% reported COVID-19 related trauma or stress. And those previously diagnosed with PTSD reported 69% or 69% of those people reported new onset COVID-19 related trauma or stress. So how is this going to play out in our office? How is this going to play out in the people that we see? And I will try to make this quick. There is no one way this is going to happen. I don't want to suggest that COVID-related cognitive or mental health consequences will necessarily be relevant in every instance. Rather, it was my hope to simply raise awareness of the potential relevance of COVID and the co-occurring psychological and cognitive ramifications of this disorder. But I can foresee a number of ways in which this could happen. I could see someone who is housed, ready to stand trial or soon to face trial, and I can see them getting infected and having cognitive or psychiatric consequences of that that might at least temporarily limit their capacity to proceed. They may require some delay in proceedings or even some cognitive rehabilitation as a result of a very bad infection that would be required before they are ready to go to trial. I can foresee circumstances in which those that are undergoing restoration therapy at the time of their infection may experience a reversal or a decline in function temporarily, or require a different kind of intervention to address the cognitive and behavioral and mental health issues that arise. I certainly see civil capacity evaluations as very likely to COVID infections. Disability evaluations, I think, are going to be, especially those identifying as long haulers, are likely to be frequent in our practices. Workers' comp, think of all the people working in those meatpacking plants who suffered illness or disability as a result of COVID exposure in those work environments. Personal and psychological injury, I think those are very potential circumstances in which we're going to begin to see COVID patients. Best I can tell, I did look for some information on this, but there's relatively little legislation here in the US that limits liability for exposure. Nevada has passed a law in August that limits liability, but also mandates sort of minimum standards to avoid liability. So if the casinos and other hospitality businesses are providing sort of a minimum standard of cleanliness and hygiene and cleaning, then they are not liable. However, if they're not meeting that basic minimum standard, then I think it is quite likely that some claim of negligence is possible. I'm certainly not advocating for anybody to sue anybody, but I'm just thinking through all of the things that we're likely to see. Many other countries have already begun to deal with these issues of liability, and I know the Senate has wanted to pass legislation that limits liability or offers protections for businesses, but that has not happened yet. In general, I'm not sure that we that we would treat these COVID-related mental health claims any differently than we would treat any other cause of mental health issues or cognitive impairment. There needs to be a clear nexus between the COVID or the virus and the mental health question at hand. We need to recognize the risk factors that are present, but not exclude the nexus when it's clear. We need to try to stay current with the COVID literature, and I think it's going to expand exponentially in the coming months and years. I think we will simply have to proceed cautiously on questions concerning the long hauler phenomena and understand that there's a lot left to be learned about what that is. And I just would reiterate what I said very early on, and that is that there remains very much that's unknown about this virus and what it does. We should be ready and we should proceed cautiously. That's all I got. Are there questions?
Thank you so much. That was like fascinating, and the hour just flew by.
Yeah.
It's over. Okay, so the first question is, have you come across any guidance about how long to wait after someone has quote unquote recovered from COVID before we conduct an evaluation with that person? So like, they have COVID, maybe are exhibiting cognitive symptoms, but we need to evaluate them for competency. Any thoughts on that?
Yeah, I mean, there's no good answer. You may have to do it serially. There may have to be multiple evaluations. I certainly think waiting until they are released, I mean, assuming they have been hospitalized, I would certainly wait until they are returned to the facility before doing an evaluation. And you may just have to use a screening instrument and test them at intervals to see when they're ready. I don't think there's any clear guidance on that yet.
Also, just real quick, for those of you that need to jump off, it is 1 o'clock. We did post the CEU link in the chat, so you can grab that. Just make sure you save a copy or take a screenshot of it, because we don't send copies of that. Okay, so the next question is, how might you address COVID-19 related cognitive or psychiatric symptoms in a report, particularly with or regarding the uncertainty regarding duration, onset, and recovery?
Another great question. I anticipate that some of these questions are going to be specific to COVID. So, I mean, the relevance to COVID and mentioning COVID should be done up front. I anticipate questions are going to be, is this person injured by COVID? Is this a realistic outcome from their experience with COVID? And therefore, it's just part and parcel of the evaluation. I think it's part of the referral question, or at least I would anticipate it being part of the referral question. If it's not, if it is just an honest, straight up, is this person competent to proceed, then I think you would address it in the way you would address any causal issue, and probably not make it central, but provide it as an explanation for why this person is not competent. This, somewhere towards the end of the report, we would say, this person was recently diagnosed with COVID. They were hospitalized for this period of time. They remain in the acute or post-acute phase of the illness, and that at this time, these cognitive or psychiatric symptoms appear to be or may be related to that. Probably not a great answer, but that's all I got.
Have you come across any research published regarding COVID cognitive outcomes and psycholegal issues?
I have not. I have looked for that, and it's not there yet. And I'm not surprised, because again, I think it's early. But clearly it's going to be there. especially, I mean, I think we're going to see a lot in this long hauler sort of context, because I think that's what's going to drive a great deal of the litigation moving forward, particularly disability. And again, I would simply argue that we wouldn't treat it any differently than we would treat anything else. We want to make sure that we do a good, thorough malingering symptom exaggeration component to the evaluation. Though, again, I think we need to be a little bit cautious about symptom exaggeration, particularly on those sort of psychosomatic scales, on things like the MMPI, because we just, this is a devastating disease. And so we may not be able to rely on some of those validity scales on things like the MMPI that we would normally in this sort of context. So we just need to be, cautious, I think, there, at least at present.
Have you come across anything discussing neurocognitive impairment or mental health symptoms in people who are asymptomatic but test positive for COVID?
Asymptomatic but test positive for COVID. I haven't specifically, though. That does, I mean, that's part of this crazy, forgive the use of that word, but this complicated, weird, long haul phenomenon. I mean, there are people on these Facebook chats. Apparently, I'm not on Facebook, but apparently there are people on these Facebook chat groups who talk about being COVID positive, but never being hospitalized, but being terribly impaired. And we just don't know. Those studies have yet to be done. And so it's going to be a real challenge, I think, teasing apart what is real, legitimate, long-term consequence of a very severe and complex viral infection versus the psychiatric elements and malingering elements that we often see in some of these circumstances.
Okay, next is, do you have the full citation for Rogers 2020?
I do. In it, when we send out the
Slides?
the slideshow, there will be a reference list at the end. I have been adding stuff as I go over the last week, so I've got several things to add to that reference list.
Great.
See if I can get out of the end of the slideshow. See if I can find that real quick. Anyway, go ahead and ask the next question. I'll see if I can find that reference as we.
Okay. Regarding the 30 suicides at Duke, are you aware of any specific?
Three, not 30,
oh.
3.
Okay. Are you aware of any specific mental disorders in those individuals?
No. And there was very little clear public communication about those suicides on campus. We sort of heard and knew that they occurred, but there was not much about those made public. And so we're not absolutely certain that they had anything to do with COVID. The timing is just very suspicious. So that Rogers paper is in the Lancet, volume 7, July 2020, in the Lancet.
Next is, can you discuss the surge of domestic violence worldwide during the pandemic?
I know it has occurred, and I know that it's a problem, and I have been probably remiss in not addressing that in this presentation. It's certainly an issue. But other than knowing that it has occurred, I don't know anything about it, unfortunately.
Okay. Do you know anything in terms of the 400% increase in alcohol, which it seems like you're assuming is an increase in consumption? Do you think that's confounded by the fact that bars across the country have closed?
I am certainly, I'm sure that that is a confound. I can't remember. Okay, so two things. That number is a nationwide U.S. number. That the 262% increase and the 477% increase in alcohol sales, online sales. That was the end of March and the end of April. I am sure that some portion of that was due to closing of bars, but I don't know that the exact timing it would be very interesting to know what those numbers are in each region relative to the presence of lockdowns, because lockdowns didn't occur nationwide. They were more restrictive in some states, and so I think you could probably tease that apart in the data. And that's from the Pollard study, and that data actually derives from a study by the Rand Corporation. And so I think the raw data is probably available on the Rand Corporation website, though I didn't look for the raw data itself.
Have you come across any discussion of dermatological symptoms in long hauliers?
No, I know they exist. So one of the things that the SARS-CoV-2 virus does is cause a coagulopathy disorder. So a tendency for blood to clot. That's part of what drives the strokes and the seizures. Is these huge blood clots form and cause strokes, but very small clots can form in the circulation system in the skin and cause some dermatological issues. There may be other dermatological issues as well, but I think some of those dermatological issues are related to the coagulopathy. My brother actually had a bizarre rash appear on his legs in November last year that nobody could figure out. And then I read something about dermatological issues in COVID, and he went and got tested and he was negative, so they still don't know what that was. But it's possible that those symptoms were present beyond the actual period of active infection, and he may have been COVID positive, but was no longer testing COVID positive. So I know it's out there, but it was just not one of the things I focused on for this presentation.
Okay, looks like no more questions. But again, thank you so much. This was really, really interesting and such an important thing for us to, at least be aware of.
Yeah.
We move forward as a community. So thanks again. We're really grateful for your time.
Absolutely. Happy to do it. Thank you for asking.
Of course. To all of you that are still on here, we'll stay on for a few more minutes to allow you to complete your CEUs survey. Otherwise, we will see you all next week. Thank you so much.
Very good. Thank you, everybody.
All right, folks, I'm going to end the presentation and within 3 minutes. So if you haven't gotten the CE evaluation link, please grab it. It's in the chat.
Oh, Julie, will I get any of the feedback from the end of the course survey?
Julie logged out.
Okay. Do you know, Anthony, if there'll be any results provided from that survey about how interested people were, that sort of thing?
Yes. We'll make sure to forward it your direction as well. The results.
Very good. Thanks so much.
Yes, that's what I was
care.
gonna say. I was gonna say I would check in with you.